Today we're going to talk about the guidelines for Chapter 1. I've gone into a lot more detail with Chapter 1 than I will in subsequent chapters. I want you to understand how important the guidelines are and figure out the best way for you to apply them when you are doing your homework. I've made some changes to the annotation, which I'll be reviewing in this PowerPoint. I've also given you some examples of the various guidelines, and from there we'll see what kind of questions come up and how you do on your homework. When you complete your homework for this class, you will have to tell me not only the answer, but the pathway that you used in the index, as well as any instructional notes, and the guideline that you applied in order to know how to code or how to sequence the codes. So let's get started. Chapter 1 only had one change to the guidelines. If you remember, your textbook has the 2016 guidelines in it. I've given you the PDF, and when scrolling through the PDF in bold font are the 2017 guidelines. And the only addition in 2017 for Chapter 1 were the guidelines around the Zika virus. Otherwise, everything is the same. So when you are looking in the code book at those guidelines, they are accurate as they are written for everything. If you make a note that don't forget about Zika. Some suggestions for annotations are given here. You can decide what works best for you, as long as there's some way that you can consistently annotate this PDF. I have Adobe Pro on my desktop, which allows me to export the PDF into a Word document, which gives me a lot more editing options. So I would suggest, if you have Adobe Pro, that you do that. Just export your PDF into a Word document and edit it. You can also print the PDF and by hand make these annotations using markers. Here's an example of what I'm doing. See if I can blow this up. That should help a little bit. The green are key terms. Underline has to do with sequencing directions. We scroll down a little bit. I use text boxes here to remind me of the code that's going to be used with the key term there in green again. And the yellow are just expansions on understanding what the guidelines are saying. So back to my slides. This is one, and here's another one. It kind of just shows you the same thing. I will make available the annotations that are here in this PowerPoint. You just have to remember that if you're going to be using the electronic document, you'll have to save a new one each time I give you one, because each chapter is being annotated. The reason why this is so is because I have only had to use this PDF this semester. It's never been the case that we didn't have the correct guidelines in the code book. Okay, so let's look at this. The first guideline is to code only confirmed cases of HIV. And what that means is whenever the physician uses the terms possible or probable or suspected or questionable or still to be ruled out, those are all things that normally in an inpatient setting you would code as if they existed. But there are certain things you do not code if the physician uses the term possible or probable. What I've given you here in this slide is a possible scenario where the physician might say, patient admitted with anemia with possible HIV infection. You would only code the anemia. I have the anemia here for the index pathway, and the rationale for the code you selected is the HIV is not coded because the physician stated it is possible, only confirmed cases are coded. And there's your coding guideline here. And then I have just a note here that this is an exception. The fact that you are coding something that uses the term possible is an exception to Section 2, selection of principal diagnosis, number H, uncertain diagnoses. And then I have it reproduced here with a copy-paste of what that says. So just remember, for an inpatient hospitalization, when you're using the terms possible, probable, suspected, in most cases, you would code that condition as though it existed. There are certain exceptions. HIV is an exception. Later on in this podcast, we'll hear about Zika. The Zika virus infection is an exception. If the physician says, I suspect Zika virus infection, you do not code it. You must code only confirmed. But we're getting ahead of ourselves. We'll go back and look at that a little bit later. There's some other diagnoses that this is the case as well, and we'll be touching base on those as we move through the guidelines for other chapters. Another guideline says patient admitted for HIV-related condition, and this particular one is pneumocystosis, which is due to the Pneumocystis carinii organism. And here I've got the pathways and the rationale. The patient's being admitted for an HIV-related condition, so your principal is going to always be B20, followed by whatever those are for the reported HIV-related conditions. If you are coding an unrelated condition, like if a patient has anemia, but the physician's saying the anemia is not due to the HIV, then you're going to make the anemia be the principal diagnosis. And underlined here with the guideline are the sequencing instructions for how the coder would sequence these diagnoses. If a patient is newly diagnosed with HIV, the point that's being made with this guideline is that whether the person was diagnosed last week, last month, 2 years ago, 10 years ago, that is not determining what the sequencing directions are. The sequencing directions are dictated by whether or not the infection is HIV-related. If it's HIV-related, the B20 is going to be your principal diagnosis. If the infection or the condition is not HIV-related, then that is going to be the principal instead of the HIV. An asymptomatic person, like this person is admitted with appendicitis, is HIV positive but no symptoms, you're going to use the Z21 code for the asymptomatic HIV. If the physician had used the term the patient has AIDS, as you can see from the guideline, you would have to use B20. Or if the patient has had any history ever of having had an HIV-related condition, then you're going to always use B20, never going to use Z21. If the patient has asymptomatic HIV infection and is on medications for the HIV, it doesn't change anything. And the guidelines tell us that if the patient is using medication for HIV, there's still going to be a Z21 if they're asymptomatic. A previously diagnosed HIV-related illness. Here this is making the point that the patient has appendicitis now, which is not HIV-related. However, last year he had a Pneumocystis carinii pneumonia, which is an HIV-related condition. Therefore, he would carry the B20 diagnosis and not the Z21. Okay, this guideline has to do with HIV infection in pregnancy, childbirth, and the puerperium. The puerperium is a period of time after the child has been delivered. And then here is your guideline for the 098 code. And I've given you a case here where the patient's 27-year-old admitted with oral thrush associated with her HIV diagnosis. She's 13 weeks pregnant. Previously, she was asymptomatic. So up until now, she had a Z21 diagnosis. But now that she has this thrush that's been associated with HIV, she's going to carry that B20 diagnosis from now on. Then the thrush is the B37.0. You always assign codes for the weeks of gestation when your 098 code is the principal diagnosis, because that's the reason why she's being admitted, the pregnancy complicated by HIV disease. Then here in italics, it says codes from Chapter 15 always take sequencing priority. That's something that we have to just remember as we're moving through the record, and I'll be reminding you of that in your homework in different places, that the Chapter 15, your pregnancy codes, always take sequencing priority. It is very, very rare that a pregnant woman would be admitted to the hospital that wouldn't have a diagnosis that starts with pregnancy complicated by, whatever the reason is for her admission. Obviously, if she's being admitted in labor, that's different, but anything prior to labor is going to be a complication of the pregnancy. I have a reference to this book that I've had the screenshot from here in a later slide, but some students find it helpful to have these types of tables. You can reproduce this table in your code book somewhere so that you have it if that's helpful. You can print the slides, however it helps you to learn these guidelines. Now we've finished the HIV guidelines, and now we're going to look at a few others. This one has to do with infectious agents as the cause of disease classified to other chapters. And what that is, if there is an infection and in the description of the code it does not mention the organism, then you're going to need to use a code from the range of B95 to B97 to be sure that you can capture the organism responsible. So here's the case in point: patient admitted for treatment of a UTI caused by E. coli. We know that the E. coli is causing the infection, but our code in 39.0 does not include the cause of the infection. So we would have to add that code. And there's also an instructional note under the N49.0 code that says use additional code B95 through B97 to identify the infectious agent. So if we again look under the main term infection under E. coli as the cause of disease, look under infection, E. coli as the cause of disease, classified elsewhere B96.20, and that would be the organism code. So now we know what the infection is and what's caused it. Then the rationale I've given you is the guideline that's used, telling us, this guideline tells us if the organism is not in the code description, then you're going to have to add a code that identifies the organism. Because we know what it is. We just have to be sure that we have let the doctor know or the reader know what the offending organism is. Okay, here I have taken that same diagnostic statement and just added the infection is resistant to vancomycin. So now we've got the N39.0 as our infection. We've added the B96.20 identifying the E. coli as the organism. And now we want to be sure we add this resistance to vancomycin because that might be important. I have here the path in the index and how you find the code. Then the rationale being we would use the guideline that was listed on the previous slide about the identifying the cause of the disease with a code from Chapter 1. And then the resistance to antibiotic, the Z16 code, we would use that as well. You notice in the guideline it only says the category. It says category Z16. That tells us that there's some codes in there, that some characters that would follow that Z16 code. So when we go to the actual category Z16 and read down, we can identify the drug that the person is resistant to, and in this case it is vancomycin. You can never go by your guidelines or your index and say that's your answer. You have to always go back to the tabular, which is all the codes in the back of the book, to verify that that's your answer. And here's some guidelines regarding sepsis. If the patient had been admitted with sepsis and the doctor did not identify a cause, then we can use the A41.9 code, which the guideline also tells us. If the type of infection is not further specified, you're going to assign code A41.9 for sepsis, unspecified organism. Now, of course, there may be times when you're working with a chart that when you first code it, it's an undetermined organism, and then later on in the hospital stay, you find out what the organism is. Then you're going to delete the sepsis code and add the more specific code. The terms sepsis and severe sepsis are different. This particular guideline has to do with the coding of severe sepsis. And you see in the diagnostic statement where the physician states the patient has developed severe sepsis and acute kidney failure. And you're going to code the severe sepsis and the failure of the kidney. And I have the instructional notes that are found in the tabular under each one of those codes. And then here's the guideline that helps us in this case to know how we would code this. The sequencing of codes is important. It's not good enough to just get the right codes. And the reason for that, as you learn more about coding, is that the principal diagnosis, the first diagnosis that you choose and the one that is chiefly responsible for the patient's admission to the hospital, that diagnosis, along with the secondary diagnosis and any procedures, the patient's age, that kind of thing, drives what's called the DRG. The DRG is part of the payment system for how the hospital is reimbursed. So you always want to accurately code the principal, because that's your principal driver for which DRG is going to be selected. We'll be talking a lot more about DRGs later in the course, but the point I want to make is that it's not good enough to just have the right codes. You must have them in the correct order. And this guideline, and many guidelines, tell us how to order the codes. This first one says a code for the underlying systemic infection is first, that's your N39.0, followed by a code from subcategory R65.2, here you go, and then additional code for the associated acute organ dysfunction, and that's your acute kidney failure here. Now the B96 code would go after N39 because they go together. The B96 is saying, wait, E. coli is the reason for this UTI. So this would be the correct sequence of this diagnostic statement. I'm going to skip over some of these. I'm not going to do all the guidelines, but just to be sure you at least have a handle on some of them. A sepsis due to a post-procedural infection. This tells us the patient developed sepsis with MRSA infection of the incision site following a total hip replacement. So the infection post-procedural, 281.4. T81.4 is going to be our code, and we put our additional characters here. There's an instructional note to use an additional code to identify the infection, and in this case it is Staph aureus, MRSA, A49.02. And here are the two guidelines that inform us as we assign codes here. The sepsis is due to the post-procedural infection. This is telling us to do the T81.4- first. And then this one is telling us if the infection, assign the appropriate combination code for the infection. Then the Zika virus just tells us if you're only going to code a confirmed case. The doctor doesn't have to tell you why he's confirming. He's just saying this patient has Zika. That's all you need as a statement. And you would code A92.5. Again, this is new for 2017. If you had the case where the patient has all these symptoms and the doctor's saying, I think it's probable this is a Zika infection, you cannot code infection with the Zika virus if the doctor's using that term, because that term means it's not confirmed. So in that case, you're only going to code the symptoms. For the next part of the podcast, I want to talk about something I call connecting the dots. It's one thing for me to give you all these resources, it's another for you to know how to use them. So I'm going to go through what my expectations are for how you're going to learn the guidelines and apply them when you're completing your exercises in this course. Number one, prior to beginning an exercise, review the guidelines for a given chapter or topic. For example, this first, week 2, we're studying chapters 1 and 2 in the code book. So you would review the guidelines for those 2 chapters prior to beginning exercise 2. Then you're going to open exercise 2. You're going to highlight key terms that remind you of the key terms that you've identified in the guidelines. Those are the ones that are in green. You have the green highlight. After you've looked at your key terms in the exercise, you're going to go back and read the guideline for that identified key term. For example, the first one we're going to look at is MRSA. If you remember your Chapter 1 guidelines, you know there's something about MRSA in there. So you'll go to those guidelines that specifically address MRSA. Then you'll complete your exercise, assign your code, and cite your guideline. So let's look. So if you remember, these are the specific topics that are in the Chapter 1 guidelines. It addresses HIV, any infection agents that are as a cause of disease in other chapters, infections that are resistant to antibiotics, sepsis, severe sepsis, and septic shock, MRSA and MSSA, and the Zika virus, which is new this year. Okay, so let's put that into practice here. I open up exercise 2. Now, when you open up exercise 2, you're going to see this first one's already been done for you, but just to walk you through this part of the exercise, I'm going to do that. So when we read the first one, MRSA screen positive, we know that in the guidelines there were specific guidelines that addressed MRSA. A screen is just referring to a colonization. That term you may remember also from the guidelines. This particular diagnostic statement does not mention an infection, so we're going to go with the whole idea of a colonization. So now you know MRSA screen or colonization, and you're going to go back, open your guidelines, and here we are. I've scrolled down to the section that addresses MRSA. The first section talks about combination codes for MRSA. That doesn't really apply here. We scroll down, other codes for MRSA. That doesn't apply here. And then here's your colonization guideline, 1C, 1E, 1C. As a reminder, this would be Section 1, C, which is chapter-specific guidelines, Chapter 1, and then E1C is just the breakdown of the guidelines as you move down a numeral numbering system. MRSA screens colonization, that's a carrier, so it is Z220.221. So I'm going to highlight that, go back in here and do this, and you can also go into your guidelines, and that is this coding guideline. And if you want to remove that highlight, you could do that. Well, maybe I can't. It won't let me. That's okay. I don't know what that's about. I would suggest that you just in some way identify your guideline. You notice how all these fonts and font sizes and fonts are different? What you can do, highlight the whole thing and go up here, and I think there are Times New Roman 12. So now they all look the same. Now that takes care of assigning your guideline, but you still have to tell me what pathway you used in the index. This should be index. So if you're looking for this in the index, and when you look these up, the main term is colonization. I'm not sure why that's highlighted. I don't know. Anyway, I'm not sure why that's highlighted, but it's okay. What's important is you've shown me your pathway and you've told me what guideline. Okay, let's look at the next one. In this one you see there's an MRSA colonization and an infection. So if you push down your control button, control key, CTRL key, you can highlight, oops, I don't want everything, MRSA colonization, push down your control key, and the MRSA infection of the urinary tract. Then you're going to push the green. So there you've got a colonization and an infection. And if you remember from your guidelines, let's go back in. And here it is right here. If a patient's documented as having both, you're going to code Z220.221 and a code for the infection. Then you would do that. So this is how I expect you to use the guidelines. you can learn them this way, but unless you are reading them at least 2 or 3 times each time you do an exercise in that chapter, you're just not going to remember them. You can't memorize them, there's too many, but you can become familiar enough with them over time that you know there's an MRSA guideline in Chapter 1. You may not remember the specific guideline, but you know it's in Chapter 1. That becomes especially important when we're looking at sequencing different codes. That, too, is difficult to memorize because it's very specific to individual cases or scenarios. So you have to always be willing to go back and look at those guidelines over and over and over. Later on, as we look at encoders and computer-assisted coding as the way this is actually completed in the field, you will find that there are edits in the software that pick up on when the coder hasn't followed a guideline. But at this stage of the game, you as a student needs to understand where those guidelines come from that are part of a software package and how you would use them. If you are coding in a physician's office or in a smaller practice, you may not have an encoder or computer-assisted coding. So a coder has to always know how to use their book, first and foremost, because that is your guide. Also, the encoder and the computer-assisted coding reference Coding Clinic, which, if you remember from your reading, is a publication that comes out once a quarter that crystallizes, if you will, guidelines or clarifies guidelines. When coders send in individual questions that they're just fuzzy on how the guideline would be applied, the people at the Coding Clinic would answer their questions. Also, I wanted to mention that hospitals have departments, large hospital systems have departments called nosology. And nosology is Nosology is a branch of medicine that deals with the classification of diseases. And sometimes you can get an answer quicker from your nosology department than you can from the Coding Clinic. But just be aware those are both resources that you might be using. Okay, the next several slides I'm not going to go over as part of the podcast, but just be aware that they are taken from this book, ICD-10 Coding Guidelines Made Easy 2017. Some students find to have guidelines and tables like this very helpful. It's not required in any way for this course. It's just a suggestion. I put some of the tables here I just put them on the document camera and made screenshots of them. You can use them that way, or you can buy the textbook if you want to do that. I've given you the author, and I've got it. I bought it on Amazon.com just for reference, but personally I like the guidelines the way I have them better than the tables. But again, you have to do what we all learn differently, and you have to do whatever works best for you. Thank you so much, and hope you have a good day.